Hello and welcome to the first AOAF webinar, Treatment of Open Tibia Fracture in Low-Income Countries. I'd like to welcome all the participants, most importantly from low-income countries. I can see a way of numbers from Nepal, Bangladesh, African country, Cameroon, and also from developed countries. So on behalf of AOAF, I welcome you all. My name is Subhas Shah. I work at one of the private hospitals which is situated east of capital city of Nepal, and my subject of interest is trauma, especially of upper extremity and lower extremity. With this, I'd like to welcome our chat moderator, my friend.
Hello everyone, my name is Nicholas Lubega. I'm a consultant orthopedic surgeon working at the BedCure International Hospital in Malawi. Our hospital is the only specialized orthopedic hospital in Malawi, and I also work at the College of Medicine in the Department of Surgery, where we teach undergraduate students, postgraduate students, as well as orthopedic clinical officers. I'm very excited to be part of this webinar, and my role will be to be a chat moderator. During the presentation, I'll be taking down questions from the participants, and I'll be answering the questions as well as we go along. At the end of the webinar, there'll be a session of questions and answers, and at that time, we shall answer some interesting questions that will have been taken during the webinar. I'm very excited to be part of this webinar, to share this knowledge with you, and I look forward to the next 1 hour or so. Thank you.
With this, in next 45 minutes, we shall be discussing regarding EU Alliance Foundation. Then we'll be discussing the main crux of the matter, how to treat open tibia fracture, especially in low-income countries. Afterwards, we'll be having live question and answer period. And if you have more question, then we can have a chat offline. So let's begin. This is a clinical picture given by Dr. Jim Harrison. He's a middle-aged lady who has sustained open tibia fracture, initially treated in a cast. Later, few days afterwards, when a window was created, we can see the pus is pouring out. Now the goose is cooked. This is unacceptable treatment in this era. We are not supposed to do this. Now, with increase in urbanization and modernization in transport methods, lots of people are buying new vehicle. And in less income countries, most people are buying motorbikes, cars, with narrow streets and limited extension of road, with increased number of vehicles, the people not aware of the safety rules and regulation, it's for sure that in near future the accident rate is going to escalate. And with increase in number of vehicles, that's for sure that severity of musculoskeletal injuries is going to increase. And that is why on WHO list, it has put the trauma from number 10 to third most important health problem worldwide. And WHO is not only institution who can deal with this burden of epidemic worldwide. And that's why we need a foundation that is called the EU Alliance Foundation, which has been formed recently, which is a non-profit organization which is dedicated to improve the fracture care, especially in low-income countries. And it's very soon is going to extend to develop a care for spine injury or also for maxillofacial injury. Now, if you're interested in EU Alliance Foundation, you can log in at our website, which is given in the slide mentioned here. and in future it's going to extend. And the basic idea of this foundation is to give a very good care for trauma. Now, moving ahead, since we have done with our housekeeping things out of the way, let's get into the real interesting things, and which is a clinical scenario, how to treat open fracture, especially in regard to tibia fracture. Now, at the end of this webinar, these will be the learning things that you have to incorporate and that you should be doing. You should be able to evaluate open tibia fracture. You should be able to specify the goals and principles of open tibia fracture management. How to know that recognition of a debridement is a key for successful management and outcome. You should be able to take into consideration what are the available resources that you have in your institution and what is the level of expertise that you have. At the same time, you should be able to select a fixation technique based on the wound characteristics, fracture pattern, and bone loss that you have. Now, we are all aware that tibia is a very common long bone that usually gets fractured because of its nature. It is subcutaneous bone, and that quite often we get open tibia fracture. As we have said, with rise in ownership of new vehicles in low-income countries, the percentage of open fracture will be more. But, my friend, the treatment still remains challenging with our limited resources, especially in the field of expertise to treat this kind of injury and with limited cost. Now, what are the goals in treating this kind of fracture? First and foremost, prevention of infection is the key to win this battle. Second is prevent further complication by soft tissue handling that has to be gentle. At the most, we have to opt for achieving union at the fracture site, and the last but not least, we have to restore the function of the limb which has been injured. Now, these are four independent goals that we have to opt for achieving each of them individually. Now, there are different classification methods of open fracture. However, the most widely, which is still accepted and used worldwide, which was developed way back in 1976 and was modified once in 1984, is Gustulo-Anderson classification. This classification system takes into consideration four factors. First, the size of the wound. Second, the level of contamination at the wound site. Third, soft tissue damage. And fourth factor is bone injury. Now, considering these four factors, it has divided into three categories: type 1, type 2, and type 3. Type 3 has been further modified into grade A, B, and C. Now, we don't find difficulty dividing into grade 1 or 2. But when you come to dividing grade 3, now there seems to be problem. When you come to grade 3B, there still seems to be a problem how to go for it, how to make a decision plan, whether to amputate or whether to salvage the limb. Now here comes another classification which seems to be very promising and which was published in JBGS 2006, which is a beautiful publication given by S. Rajasekharan, that is called as Ganga Hospital Score system. Now, why this system has been developed? This system basically is here to help with the fracture that falls in Gustulo 3B category, because at this category they have poor inter-observer agreement rate and they have difficult decisions whether to go for salvage the limb or for amputation of the limb. Now, while talking about Ganga Hospital Open Injury score system, there are four factors that has been, or we can say four components that has to be considered. The three factors which is belonging to the injured limb and one factor which is regarding comorbidity factors. In comorbidity factors, there are 7 of them, to list few. First is age of the patient, second the comorbidity conditions, and third polytrauma. There are just others. So for each of these components, you give a score of 2 if they are present on the patient. Now, other component regarding the injured limb, there are three components. First is skin and fascia, that is covering structure. The second component is bone and joints, that is considered a combined skeletal structures. And third is functional structure, that is muscular tendinous and nerve units. Now, each component has been given a score from 1 to 5, 1 being least damaged, 5 being the most damaged. So, in between, you have a 3 score. So, after giving a score, let's say you give a score of skin fascia 3, similarly, give a score bone and joints 3, and the functional structure, that is third component, you give a score of 3. So you combine all these three and the total sum up will be coming out 9. And again you have to add up the core factors. Based on that you can add up depending on how many factors is there. Now you gradually sum up whole of this and you make a list. Now afterwards you can divide it further into 4 categories. Grade 1, the score if falls between 1 to 5. Grade 2 if it falls between 6 to 10. Grade 3 anything between 11 to 15. More than 16 is already grade 4. So it has a clear-cut guideline. If the score is between let's say lesser than 16 or 14, 14 is a clear-cut indication no, you are planning for salvaging the limb. But if you have a score, let's say more than 17, you are opting for primary amputation. That's for sure. Now there's something called gray area. If a score is between 15 and 16, then depending on your level of expertise, your institution protocol, either you can plan for primary amputation or you can plan for salvaging the liver. But it doesn't give a clear-cut guideline. But of course, score 14 or less, you are opting for salvaging the limb. That's for sure. Now let's look at this example. If you see this 4 clinical picture, all falls in Gustulo 3B as for Gustulo classification. But Gustulo cannot guide which one to amputate and which one to salvage. But if you go according to Ganga classification score, you have to look at the skin, bone, muscle, and other comorbid factors. And again, as I have said, you have to add all those points, and at the end, you pile up all those points. And if you see the picture on your left side, which is almost going to amputate, so you go for primary amputation. But other 3 clinical pictures on your right side, it's better you go for salvaging the limb. So that's the difference between Gustulo and Ganga classification. So we hope that in near future Ganga classification is being widely used in low income countries. Now let's look at an example. If you see, this is a clinical picture with a 40 years male HIV patient, Gustulo 3B fracture of the tibia. This was attempted for salvage. An external fixator was applied and negative pressure wound therapy dressing was done on a regular basis. And when you look at the second look after a few days of time, then you are nowhere. What to do now? Now you are thinking for below knee amputation. Now, if you go back and look at the first go, then you could have done like this. You could have see the Ganga classification score. We have done a scoring system with the skin, the soft tissue, or that is a skeletal structure, and musculotendinous structure, and coronal factor. If you consider all those points, probably if you add those points, it might go on beyond, let's say 16 or 14. So primarily you could have done amputation. So that's the beauty of going for classification of Ganga score. Now let's make a question to you guys. Which classification system do you routinely use at your hospital? The option will be for this: A. Gustulo Anderson classification, B. Ganga hospital classification. Both Gustulo and Ganga hospital classification or D, other? Let's vote. Okay, yes. So here we have the vote, and almost 94% of you guys have said that Castillo-Anderson classification is used. Yes, we use Castillo-Anderson classification most rampantly around the world. That's for sure. Thank you. So we will be moving ahead. Now, what are the principles while treating open fracture? We have to treat open fracture as a whole, not only as a fracture, but as a patient, as a not as a whole, but as a whole of the patient. You have to treat as an emergency basis. Debridement and re-debridement is the key to win this battle. Stabilize the fracture with the armamentarium that you have. Opt for early closure of the wound. Go with antibiotics as soon as the patient arrives at your institution, and do remember what are the limb-threatening conditions that you can come across. Now, while treating the patient as a whole, do not be distracted by orthopedic injury only. You have to remember ATLS guideline. What are those? You must be aware of that. Airway, breathing, circulation, disability, and of course exposure. But at times you might miss some subtle injury which seem to be very minor but which could be life threatening. So please have a habit whenever you come across orthopedic injury, you need to examine a whole patient in total. You have to feel and see that these open fractures are emergency. In many hospitals, open fractures are not treated as emergency. That's very sad. So whenever you are taking operation, taking the open fracture to the operation theater, the priority will be given to, let's say, some other patient, especially with having a cesarean section. So OT is full and you have to wait in the queue. This mostly happens in low-income countries where in a hospital you have only one operation theater. So, dear friends, it's a high time now. Please go and demand for an extra OT, which is especially for orthopedic trauma care, which should be running round the clock and get a dedicated orthopedic trauma team, which could support you to give a care of the injured patient round the clock. That's mandatory. Now, regarding debridement and redebridement, infection kills, and infection is the worst enemy that we have in these days. So, a clean, healed wound with an unaffected non-union with bone loss is acceptable, and in fact, it's much better than having a infected non-union with no bone loss. So always aim for no infection, clean wound. That what we should get with debridement and redebridement. Now, while doing debridement, you must have applied tourniquet. You could apply it, keep it as such, but not to inflate it if it's not required. Use intravenous antibiotics. The golden hour of 6, I don't know, maybe as early as possible. I'm very happy, especially in developing country, most of the paramedics and junior doctors are aware that whenever they see, they give a TT shot, stat intramuscular. That's very good news. Now, when you see gross contamination, try to take it out. Now, while doing debridement, you have to be systematic. It has to be clockwise from superficial to deep. Each tissue has to be taken at a time, and you have to do copious lavage. How much we'll be discussing if time permits. And my friends, please remember that solution to pollution is dilution. So you cannot remove all the infection at a single go, but of course you can dilute it. While talking further on debridement of a specific tissue, while taking out the skin, you have to be generous, but at the same time, try to prevent as much as skin as possible. If especially if the skin belongs to the palm or foot, especially on the plantar aspect. Now, how to go for fat? You have to be quite aggressive. with the taking of fat. Now, how about muscle? You can evaluate the muscle by looking at these four things, whether the muscle is viable or not. First, look at the color. If it is deteriorate, yes, it's good. Then look at the consistency. Firm, very good. Then you have to look at the contractility. If it contracts, it's viable tissue. Now again, if you cut at the muscle and if it's bleed, yes. Based on these characters, you can easily delineate whether it's a viable tissue. If it is viable, leave it. If it's not viable, just remove it. Now talking about bone, you have to remove avascular contaminated fragments, but try to protect soft tissue attachment to the bone. Even if it is the size of this bone is small, try to preserve it and try to retain the key bony fragment, especially if that bony fragment is belongs to articular surface and it adds in stability. Now, sometimes avascular bone is also used to maintain length, rotation, and axis, as has been beautifully depicted in this clinical picture. The middle segment is maintaining the length of the bone, so try to preserve it. Once the purpose is solved, if you think that the bone is of no use, then later you can discard it. Now, regarding fracture stabilization, there are different methods how to stabilize the fracture. The things which is commonly available in low income countries is plaster of Paris. We can easily use a slab or a cast to treat this kind of fracture, which is quite rampantly used, especially in Gustilo 1 or even in Gustilo 2 fracture. Now, use of external fixator is gold standard in care of open fracture. Either you go for using a monolateral or a circular frame. It based on your wound size, your level of expertise, all those factors. Now, if you are expert enough and if your level is very good or you work in a good hospital, you can opt for going for IM nailing. But if none of these things are available and you are only left with traction, then you can go for a skilled traction, of course, but it has to be on temporary basis. Later on, once the condition is favorable, you can change it to some other form of treatment. Now, I do not want to talk much on external fixator, but since I'd like to add some points, these are the factors. While placing the pins in regard to wound, you have to take care where to put the pins. Especially if you are talking about tibia, you must have heard the safe zone, which is on the medial side of the tibia. There are no nerves or vessels, so you can easily put this pins on that side. And while also putting pins, you have to consider that you might be doing some other procedures, some definitive fixation later on if the condition wound gets better. So you might be thinking that these pins should not be in the point where you make some definitive method of fixation. So that's important thing to consider. Now, what are the advantages? There are many advantages. To list a few of putting external fixator. It provides stabilization. It decreases hematoma. It also facilitates in wound care. And yes, it can be converted to other treatment methods if required later. Now, thinking about early closure, timing of closure, yes, you can go for primary closure. If you think that the wound is quite clean enough and there were no chance of infection, there's not much comminution, so you could primarily close the wound. But dear friends, we do teach our junior doctors and residents that you opt for delayed primary closure. Having said that, how delay? Less than 7 days. It's better to close the wound within 7 days of time frame. That's advisable. Now, what are the methods of closure? We have a split thickness skin graft, we have full thickness skin graft, we have local rotation of flap. Now, these things can be easily done by orthopedic third year resident or a consultant. But if you opt for going for muscle flap or let's say cross leg flap, then at that times you might need the help of plastic surgeon, which at times might not be available in your center. So if you think that these things has to be done, it's better to refer those patients to higher centers where the availability of plastic surgeon is there. Now let's look at the clinical picture. On your right side, you can see the fracture has been well stabilized by putting an external fixator, and now it's time to close the soft tissue. So a rotation flap has been done. You can adjunct or you can add something like split thickness skin graft on top of that, and it's going to heal. So that's an example of closing the wound. Now let's have another question. Do you have access to a plastic surgeon for a flap coverage in your institution? The answer will be yes if you A, or B, that means no. Let's hear it. Okay, so we have the result, and 60% of you say that yes, you do have a backup of plastic surgeon. That is very good, but 40% you don't have. So I'll advise them, if you have those kind of patient which you cannot deal with, it's better to refer to center where you have a plastic surgeon. So moving on, uh, talking about antibiotics, it has been proven that antibiotics do have a role to decrease the infection rate, and open fractures are by and large is contaminated. So early treatment is advisable with antibiotics. So how to go for it? If you are having grade 1 or type 2 fracture, you start with intravenous cefazolin. Then if you have grade 3 fracture, you can add aminoglycosides. You have to. And if you think that it's a farm or soil injury, then you can add further intravenous penicillin. Remember, these has to be intravenous IV antibiotics, and it has to be continued at least 72 hours after the first debridement. Now, you may prefer to continue antibiotic longer afterwards. However, there is no definite guidelines on this, how long to go for it. Now, talking about rehabilitation, which is one of the most important thing. In this case, you can see a clinical picture where the fracture of the tibia has been stabilized, putting external fixator, and there is a flap which has been covered and which has been thrown. Now we need to have a plant grade fluid. Now this can be easily achieved by putting a bandage encircling the foot, and which is tied to one of the pins. Now, most of us are developing country do not have the luxury of having a trained physiotherapist. So in this situation, you can teach the patient himself or one of the family members how to do this one. So that becomes easy on rehabilitation part. Now let's look at the case which happens to be of mine. This 65 years old gentleman, he's a motorcyclist, and he had sustained head-on collision with another motorbike, and he presented in our hospital with a wound on right distal third aspect, medial aspect of the leg, and there is no other major injury sustained. And the size of wound was 4 by 3 centimeter, and the bone was protruding. Yes, of course, the wound was contaminated. So emergency department, we resuscitated the patient, and irrigation of the wound was done with plenty of normal saline. I hope that's quite available in your part also. And a sterile dressing, splinting of the wound was done, and tetanus shot was given, intravenous antibiotics was started, and X-ray was obtained. So we send the patient for an X-ray, and here is an X-ray of that injured limb. So you have, as per AU classification, you can put this as 4, and since this is distal part, so 4-3C, there is less combination in articular part, so 4-3C2. That's how it goes, I think. Oh, then afterwards, the patient was taken to the operation theater, and in operation theater, the debridement of the wound was done. We go systematically, as we have said earlier, from superficial to the deep. And then afterwards, the fracture was stabilized, putting an external fixator, and wound was left open. So that's the message I want to convey. Leave the wound open. Do not try to close it primarily if you think that it's a contaminated wound, as in this case. And afterwards, the wound was taken care of in ward by daily dressing of the wound. And if you see the immediate post-operative X-ray, you can see the alignment on both the tibia side and on the fibula side has been taken care of, and gradually the wound got better. Now, 2 weeks after the external fixator application, wound had healed and the swelling subsided. Now we plan for definitive treatment of the fracture. So in this case, since on the tibia side there is a medial malleus fracture, this is articulars, we opted for absolute stability. We put a screw with a washer. Whereas in case of fibula side, we opted for a plate in a neutral mode. Now, in after a few weeks' time, let's say 3 weeks after the second surgery, we can see the wound has healed nicely, and but still there is a swelling. So rehabilitation process was started, and the swelling subsided gradually. 3 weeks after, if you look at the X-ray, the fracture is in healing is in progress, both on the medial malleus side and also on the fibular side. And 1 year postoperatively, if you look at the picture of our X-ray, you can see the medial malleus fracture has healed, and also on the fibular side, the fracture is consolidating. So that is very good. And 1 year postoperatively, if you look at the clinical picture, the dorsiflexion and the plantarflexion is quite good. We have obtained a plantar foot. There's no edema, so that's quite a functional limb. Now, I'd like to invite our chat moderator, Nicholas, for live question and answer period.
Thank you very much, Dr. Your view. And we are going to attempt to answer as many as we can in the next 15 to 20 minutes or so. There's a doctor from India who asked about the irrigation, and he asked what's the best irrigation fluid that can be used. Studies have shown that there is no real fluid that is much better than the others. Dr. Rahman et al. Did a review of many of the fluids. He looked at studies that looked into this issue. Dr. Rahman et al. Is a doctor with McMaster University in Ontario in Canada. And he looked at the various fluids in terms of how much should be used, under what pressure. He looked at studies that looked into the number of fluids and at what pressure. And he realized that, according to the studies, low pressure under gravity is the best, tap water to remove contamination, and normal saline. So the general guideline is use tap water and then use normal saline. Dr. Subhas, can you add on this?
Oh, so that's a great question, and thank you, Nicholas. You brought this up. Yes, I also agree that the best solution, however, still is normal saline. Now, there are many studies, and might be there will be more studies, but as if now, normal saline remains the fluid of choice to wash the open fracture. Now, how much that depends on the size of the wound, and depends on the institution also. Pressure, my friend has also already been described low pressure, not high pressure. So yes, I fully agree. Regarding tap water, yes, you can go for it, but in our part of the world, I think that normal saline is quite rampantly available. So it's better if you go for normal saline wash at low pressure. Yes, that's all I have to say. Thank you.
Much. Dr. Subhas. Now, another doctor who was asking this question from Nepal asked about the Ganga score. The question was, is the Ganga score widely accepted across the world? Now, the Ganga score was developed by Dr. Rajasakaran in India, having looked at the disadvantages that were being presented by the Gastillo-Anderson for the classification of 3B fractures. As my colleague has said, in as far as the 3B fractures are concerned, these have got a wide spectrum, and the Gastillo does not help with salvage as well as decision-making in amputation or salvage. The Ganga score is accepted in such a way because it can help with predicting what limbs are going to be salvaged and what limbs will not be salvaged. If you have a score of 14 and below, those ones can be salvaged, but a score of 17 and above, those limbs should be primarily amputated. So to answer your question, the Ganga score is getting more and more widely used, and it can help in decision making, especially in the developing world. Dr. Subhas.
Yes, I also agree with you, Nicholas. Ganga score is a very good classification system which talks on each tissue separately. Now, let's say there are three components for injured limb. Let's say for a skin, and is that you can grade from 1 to 5. Now, if you have a score of 1 to 2 on that particular segment, let's say skin, then you can say that you don't need some special procedure to get rid of this skin condition. But if you have a score of 5, that means for the skin to heal, you need multiple surgeries. The treatment cost is going to escalate, and at the end result might not be going to get good. So I mean to say, or to sum up, Ganga Hospital is going to be the future how to classify the open fracture in future. Hopefully, that's what I have to say.
Thank you very much, Dr. Subhas. We got another question, and the person who asked the question, the doctor was asking, what is the best time to do a debridement? Is the 6 hours still the gold standard? Now, studies have shown that the earlier you do a debridement, the better the result. However, some studies again done by Raman et al. In reviewing the various studies concerning this, they said that probably the time of 6 to 8 hours may not be the gold standard at the moment. However, in Africa, where the patients usually present late, where the patient may not have had antibiotics, they're referred late, and there is no guarantee that the patient will get operated in the next theater space, we usually say that debridement is a surgical emergency. So as soon as the patient comes in, we treat it as a surgical emergency so that the whole team knows that this is a surgical emergency. Debridement has to be done at the earliest possible time. So as far as Africa is concerned, or the developing world is concerned, debridement is a surgical emergency, and it has to be done as soon as the patient arrives. As soon as you've prepared the patient for the operating room, it's best that you do it there and then. Dr. Subhas, what's your experience with the debridement, and what is the practice in Nepal?
Yes, thank you for the question. Yes, I fully agree with you, Nicholas. In our part of the world, the same problem, late presentation of the patient. Even if the patient arrives at hospital, I might be off the duty, anesthesia not there. So let's say the time frame of 6 hours seems to be a little bit tricky, but yes, I do agree on sooner the better. So have a team standby, since we have already emphasized that point that it an open fracture is an emergency. So you have to treat it as an emergency basis. There is no shortcuts. So to sum up, yes, this is an emergency. Sooner the better. Don't wait for 6 hours to pass on and then you take the patient to the operation theater. Let's say, how about the patient if you receive, let's say, after 24 hours? Still, you have to go and take the patient to the operation theater. So yes, to sum up, sooner the better. That's my final word.
Thank you very much, Dr. Subhas. So the sooner the better. The sooner the debridement is done, the better. Now, Dr. Anab Sira from India asked a question. How can you be sure of no infection to go for primary closure in fixation of a contaminated wound? Now, Dr. Anab from India, thank you very much for that question. Now, it depends on the wound. It depends on the timing that the patient has come to the hospital. If the patient has got a grade 1, there's still a grade 1 injury, the wound is clean, the patient has come within probably 3 hours or so, less than 6 hours, and you can do primary closure if there is no tension in the wound. If the patient comes late and the patient has got a contaminated wound, it is probably best that debridement is done, have a clean wound, put the patient on antibiotics, and then leave the wound open. Then come back for a second look, and at that point, you can do a delayed closure. We recommend that the closure should be done at the earliest possible time, possibly within 7 days or so, when the wound is absolutely clean. If the wound cannot be closed if there is a lot of tension and you cannot close the wound, then there are other modalities of closing the wound. These include skin grafting or a local flap and skin grafting. But the teaching is do close the wound within 7 days. Studies have shown that if you wait for a much longer time, then the infection rate goes up much higher. Dr. Subhas, any additions?
Yes, thank you, Nicholas. Nothing to add much. How to know that the wound is not infected? I don't have answer, but depending on your level of expertise, depending on the patient presentation to your hospital, what is his history, type of fracture the patient has, these are the guidelines. And if you have listened to the webinar, we have emphasized that delayed primary closure as far as possible. That's what we taught or emphasized on this lecture. Yes, somehow, as my friend has already mentioned, that type 1 fracture, which you find that there is not much contaminated, yes, you can opt for primary closure. But that again depends on your expertise, of course. That's all I have to add up.
Right. Much, Dr. Subhas. Now, Dr. Flora from Cameroon asked a question. Is the tourniquet absolutely needed during the debridement? Tourniquet has been an issue of controversy. Some people advocate that while you're doing debridement, you've got to put a tourniquet for various reasons. The argument is, number one, you have a bloodless surgery. Number two, you can see what you're doing because the field is bloodless. And number three, you can be able to actually remove all the contamination because you are looking at it. Now, argument against tourniquet include the fact that you cannot quite see which is the tissues that are dead and which tissues are not dead. And if you put a tourniquet, that may increase ischemia to the limb that has already been injured. So the general guideline is put a tourniquet, but do not inflate it, all right? And do your debridement with a tourniquet on, but not inflated. Now, if you come across too much bleeding, then you can inflate the tourniquet and then later on deflate the tourniquet to see how much debridement you have done. That will help you differentiate between the dead tissues and the tissues that are not dead. So yes, the answer to that would be I would put on a tourniquet, don't inflate it, do my debridement, but if need be, I can inflate the tourniquet. Dr. Subhas?
Thank you, Nicholas. That's a pretty good decision or answer, I must say. Yes, you have there a tourniquet which was there applied on a limb. Uh, but in case of emergency, let's say you have arterial bleed and you can control and you can put a tourniquet on and you just ligate that artery and then again you can deflate that. So that's what I want to add or emphasize is that that's just something to use as an adjunct while doing a debridement, not to keep it on, as my friend has already said. Thank you.
Thank you very much, Dr. Subhas. Now, we got another question. This question has come from Africa, and the doctor is asking, what do you see as the biggest problem of treating the open tibia fractures in Africa? Thank you very much for this question. I think this question is best illustrated with a story. And this story is a common story in any part of the developing world. Consider a 25, 26-year-old man who is on a motorcycle. In some parts of Africa, we call these border borders. These are motorcycles that move people in the busy centers. Because of the traffic jam, people usually jump onto these border borders and they move from one part of the town to the other. And these are very common injuries. So as the patient is being moved from one part of the town to the other, because of the too much traffic, he gets injured and sustains a 3B open tibia fracture. Some good Samaritans bundle the patient onto a pickup or a truck and take him to the nearby health center. At the health center, the first person the patient sees is a nurse aide. The clinician is not there. All the nurse aide does is to put some bandage and send the patient to the next level hospital, which is the district hospital. At the district hospital, the clinician who is there is not a doctor, he's usually a paramedical person, and they may be busy in doing other cases. Usually there may be obstetric emergencies, usually there's no drugs or there's no normal saline and so on. So at the end of the day, the patient is put in a corner somewhere, and the first time they get the debridement is usually probably 17 or 18 or even 24 hours post-injury. So this story is a common story in Africa or in the developing world. You see a patient who has got an open tibia fracture. It's not debrided until many hours later. They do not get early antibiotics. They do not get proper stability or stabilization for various reasons. And the skills of the clinicians who are there may not be may not be high enough to do an external fixator or an intramedullary nailing. So these are the problems that we have in as far as treatment of open tibia fractures are concerned in Africa. Dr. Subhas, in Asia, what is your experience? What are the biggest problems that you face in treatment of the open tibia fractures?
Nicholas, the biggest challenge still remains the patient presentation at the hospital, as you have said. When the patient presents, it's not 6 hours, it's 12 hours, 16 hours. It's quite late. By then, the infection has already set in. So, infection, the worst enemy of orthopedic surgeon, will deal quite a lot. So that is the biggest challenge, and I think it's going to be absurd, as I have spoken on that part, with the increase in ownership of the number of vehicles, more traffic accidents is going to happen, and that's how the presentation to the hospital, where the availability of resources, the trained manpower, and availability of theater is still tricky. So that is the same, almost same what you have said. So nothing to add on top of that.
All right, thank you very much. Thank you very much, Dr. Subhas. We've got a question from Mexico, from Dr. Alejandro Bello, and he says, Why do you only use 6 liters of saline solution for irrigation and not more or another type of solution? Dr. Bello from Mexico, thank you very much for that question. I think I'll go back to what Dr. Subhas said and what I also said. We said that studies have shown that you have to use any solution that you have available. Usually normal saline is the solution that is usually available in most hospitals. We also said that if the wound is grossly contaminated, first use tap water to remove the gross contamination. After the gross contamination has been removed, then do the draping and creping, and then use normal saline while you're debriding to further clean the wound. So yes, use tap water, or if it's available, usually it is available in the operating rooms, and then normal saline is used. A lot of studies have shown that is it low pressure, is it high pressure, should you use antibiotic solution or normal saline without antibiotics? And the conclusion from it is that there's no significant difference using antibiotic-laden solution or just plain normal saline. The key is good debridement, use as much fluid as you can, early debridement, early antibiotics, stabilization of the fracture is important to prevent infection. Those are the key in managing these wounds. Plus also early closure of the wound. Do not wait too long. But the 6 liters has historically been the teaching, but the science to confirm that is wanting. Thank you.
On top of that, it's not about how much liters. The idea is we want a clean wound. Now the standard teaching is 6 liters will do the justice to remove all those dirt, and we can get a pretty clean wound afterwards. So most of the time you might not have even 6 liter. So it's not about liters. It's the idea of getting a clean wound at the end of the day. So that's what we want to pass this message to you guys. That's all. Thank you.
Thank you, Dr. Subhas. Dr. Jesus Hambedo Gonzalez from Mexico is asking about the antibiotics. The question is, for how long do you use antibiotics after the final debridement? By extension, I could extend that question into what type of antibiotics would you use? Well, the teaching is, number one, you must use an antibiotic that will act against gram-positive organisms. And this is usually a first-generation cephalosporin. So first-generation cephalosporin as early as possible, preferably 3 hours post-injury. If the wound is a 3B wound, you can add another antibiotics on top of the first-generation cephalosporin. And if the wound is a farmyard wound or marine injury or sewage, has got contamination with sewage, then you must add an antibiotic that will act against anaerobic organisms as well. Studies have shown that giving antibiotics for 72 hours and then close the wound and then 24 hours post-closure, that is usually enough. There hasn't been much difference between giving long-term antibiotics 10 days, for example, compared to the regime of giving for 72 hours, and if you're to continue, just 24 hours post-closure of the wound. That is the general teaching, and with the evidence that we have at present, that is what we'd advocate for.
Yes, that's a very good question that has been brought. But in many centers where I visited, that they keep on going for antibiotics, using for days and days. Let's say 7 days, 8 days, but they don't have any publication. So I don't know. Maybe as my friend Nicholas has rightly said, 72 hours after the first debridement, and let's say 24 hours afterwards. But after that, there is no conclusive evidence that how long to use. And at this time, we don't want to give you suggestion that use antibiotics oral or intravenous for this long. But yes, of course, 24 hours after the closure, it's recommended. That's all I have to say. Thank you.
Thank you, Dr. Subhas. We've got time for one more question, but after the webinar has closed, we shall have more questions to answer in the chat room of this webinar. So please do not go away. We shall answer some more questions in the chat room. However, we've got time for one more question. Now, this question is from Dr. Ritabar Kumar from India. And the question is, what are your thoughts on swabbing of the wound before and after debridement? Now, before and after debridement, do you swab the wound? Studies have also shown that if you swab the wound before the debridement and after the debridement you still swab, there is no studies that show that actually the rate of infection is decreased by swabbing, by taking a culture. Also, in the developing world, usually we do not have even the culture swabs to do this, to take the culture. The lab may also not give reliable results. So, the general teaching is follow the principles that we have outlined, which are early debridement, which are early antibiotics to cover gram positive, gram negative if the wound is also, is much bigger, like a 3B, early stabilization and early closure. So you wouldn't want to waste time taking a swab and then waiting for the results before you give the antibiotics. Past swabs may not help in the outcome of infection of the wound. Thank you very much. Well, do you have an addition to that?
Yes, thank you, Nicholas. We have already added on that. We have said that antibiotic has to be continued 72 hours after the first debridement. And for swab, to get a culture report, you took at least 72 hours. So I don't know, maybe it's not going to be much help. But even though if the infection is going to prolong, it's a wise decision or a nice idea to take a swab and have a look what type of organism is there. So that's all I have to say. Thank you.
Thank you very much, Dr. Subhas. The time for the webinar has come to an end. However, we are going to continue in the chat room. I'd now like to hand over to Dr. Subhas to give us the take-home message from this talk. Thank you.
Okay, so now we have come to an end of this webinar. So I would like you guys to have something to tell at the end of the day for last 45 minutes. You are supposed to apply a ATLS protocol whenever you see a fracture patient who have open fracture. Debridement still remains the key to win this battle. Appropriate use of antibiotics and dressing is very important. The skilled management of soft tissue is very vital, and that has not to be left to the junior resident or the junior most doctor. It has to be well supervised by senior doctor. The stabilization of the fracture, depending on where it is, which part of the bone, and early closure of the wound is ideal, and that is being recommended. Now, I'd like to thank Dr. D. Jayaramaraju, who is from Ganga Hospital, India, for giving his nice picture for this presentation. I would like to acknowledge Dr. Brian Bronstein from South Africa for giving the content of this webinar. And I would also like to thank Dr. Jess Bates from Queen Elizabeth Hospital, Malawi, for giving his inputs. And at the end, I would like to thank AO Foundation, AO Trauma, AO Education Institute for bringing up this topic as a webinar. I would also like to thank all of you for having a patience to attending this webinar. And I would like to welcome you probably next year in distant future for upcoming webinar, which will be about pediatric injury around the elbow. So till then, bye bye and thank you.